Good evening, everyone. I'm Tony Segreto, and once again, so honored to be your moderator for tonight's In the Know Town Hall. We welcome you to our continuing series, The Science of Aging, which tonight will focus on an incredibly important topic, our heart health. And how perfect is that? Because February is when we celebrate American Heart Month. You know, this is the time when we should all be encouraged to focus on ways to protect our heart and to learn about the latest advancements in cardiovascular care. Why is this so important? Because according to the CDC, one person dies every 36 seconds from cardiovascular disease, making it the leading cause of death in the United States. Thankfully, we have an incredible, and I stress incredible, team of physicians and researchers at UHealth who are continually finding new ways to eradicate heart disease and stroke. Our panelists tonight include some of the most prominent experts in cardiology worldwide in interventional cardiology, cardiothoracic, and vascular surgery. They will help us explore the newest innovations in research and treatment. They include Dr. Omaida Velasquez, the chair of the DeWitt Daughtry Family Department of Surgery, and David Kimmelman, endowed chair in vascular and endovascular surgery. She will take part in the question and answer session tonight, along with Dr. Joseph Lamelas, chief of the Division of Cardiothoracic Surgery, who was world renowned for developing minimally invasive valve replacement techniques and surgical interventions. Dr. Jeffrey Goldberger, chief of the Cardiovascular Division and an expert in cardioelectrophysiology, and Dr. Eduardo De Marchena, the director of interventional cardiology and an expert in structural heart and valve disease. See what I mean? As we like to put it, this is the Mount Rushmore of cardiology when it comes to UHealth and literally around the world. You know, it's a world-class group, as you can see, and tonight we have them for an hour. But before we get started, let's go over how you can participate in tonight's conversation. After Dr. Velasquez has delivered her opening remarks, all the panelists will answer the questions that you've submitted over the last few days. Now, you also will have the opportunity to submit questions tonight during this program live. For those of you who have joined us before, you know the drill. For those of you who are new, it's really simple. At the bottom of your screen, there's a Q&A feature. Just send us your questions. We promise we'll get to them, as many of them as we can tonight. We also want to remind everyone that all the questions submitted are anonymous. So let's get our program underway. Let's not waste any more time. It is my pleasure to introduce Dr. Omaida Velasquez. And Dr. Velasquez, we know how busy you and all the other doctors are. We are so thrilled and honored that you can be with us tonight.
Good evening, everyone, and thank you, Tony. This is indeed a perfect moment to talk about our heart health. Now, understandably, we have all been consumed by the impact of the COVID-19 pandemic this year and last year, but truly maintaining our cardiovascular health is something that we really need to focus on all year round. Before we continue, I would like to acknowledge all of my colleagues in the Division of Cardiology, Cardiothoracic, and Cardiovascular Surgery. They are truly an amazing group, and they are committed to saving lives and finding the newest innovation to combat cardiovascular disease. So you may ask, what exactly is cardiovascular health? Simply put, it's the health of not only your heart, but your vascular system as well, which is comprised of all those blood vessels that transport your blood to and from your heart. When your cardiovascular system is not working well, it can lead to many health issues, including coronary heart disease, stroke, heart failure, arrhythmias, heart valve problems, and even leg amputations. Now, most people are not aware of this connection between the heart, the brain, and the legs. And the connection is through a single disease process, which you might have heard about. It's called atherosclerosis. And basically, in atherosclerosis, there's a buildup of plaque in the wall and the inside lumen of the vessels that carry around our blood. And it is basically a universal disease of aging. It strikes to different degrees every human person walking this planet Earth. And sometimes it can start as young as people in the 20s, 30s, 40s. This is why we are continually pursuing innovative research that will lead to the newest and least invasive diagnostic, medical, and surgical techniques and treatments. And my esteemed colleagues here have made incredible advances in procedures like heart vessel mapping, coronary artery revascularization, limb salvage, stroke treatments and preventions. We are also instituting minimally invasive aortic valve replacements in cardiac surgery without having to resort to surgical open heart procedures. And these treatments are options in which Dr. Lamelas is a world-renowned pioneer. We hope to discuss all these topics tonight and look forward to answering your questions. Back to you, Tony.
Dr. Velasquez, thank you. And thank you for setting the stage as we move into the Q&A portion of this event. We have so many questions already submitted. So let's turn our attention to those questions. Dr. Goldberger, the first one is for you. I would like to know the best treatment for arrhythmia and atrial fibrillation.
Okay, thank you for that question. So I've been a cardiac electrophysiologist, which means a heart rhythm disorder specialist for over 30 years. And the field has really undergone tremendous transformation in the 30 plus years that I've been in it. We went from very rudimentary treatments 30 plus years ago to now really having very high-tech and advanced treatments for heart rhythm disorders. The two general approaches that we have for heart rhythm disorders are either medications, and there's many different medications that can be used for this, or a procedure called a electrophysiology study with what we call catheter ablation. And that involves basically placing a wire through the blood vessels in the leg, and it gets snaked up into the heart. And the concept behind catheter ablation for arrhythmias is to find where the arrhythmia is coming from and either burn it or freeze it. And then that makes the arrhythmia go away. For many of our arrhythmias, the procedure has 95 to 98% success rates, which is really awesome. And it's certainly a lot better than medications, which tend to have success rates of only 10 to 40%. Now, atrial fibrillation, which is actually the most common heart rhythm disorder that we treat today, is actually a bit more challenging than most of the arrhythmias that we use catheter ablation for. And the reason it's a bit more challenging is that we don't really have yet a great method to know exactly where atrial fibrillation is coming from. So all of the ablation approaches that we use today are what we call empiric. They're based on our best guess for where the atrial fibrillation is coming from. So it's a procedure for atrial fibrillation that has made tremendous advances over the last 20 years, but we have a lot of room for future improvement. And that's really one of the areas that we are focusing on, is how to make that dramatically better than it is currently. And just to give you an idea, depending on the kind of atrial fibrillation that a patient has, success rates can range anywhere between 50 to 70%. So that's substantially less than the kind of success rates of 95+% that we hope to achieve for most arrhythmias.
Dr. Goldberger, thank you so much. Dr. Velasquez, this next question is for you, and you touched on this in your opening remarks. What, if any, invasive and non-invasive methods can be used to reduce plaque buildup and or calcification in the arteries?
Yes, so the most important thing when it comes to reducing the buildup of plaque in the arteries is as simple as a healthy lifestyle. So a diet low in fat, as much exercise and walking as possible, and a very detailed discussion with your primary care doctor and your vascular specialist about what are the risk factors for plaque buildup. Is it hypertension? Is it high cholesterol? Is it diabetes? Is it smoking? And trying to control those risk factors as much as possible, and instituting what we call optimal medical therapy. And that's really the least invasive. Optimal medical therapy can take a person that has some plaque buildup in their 40s and stabilize that person for their entire long, healthy lifespan. And that includes simple maneuvers like a baby aspirin and some medications to lower cholesterol, for example. Once the buildup goes beyond what can be handled with optimal medical therapy and lifestyle choices and lifestyle optimization and diet, healthy diet, then there are things that we can do that are very minimally invasive. For example, if the buildup in the leg arteries is not allowing the person to walk because they have severe pain, that affects their entire body. It's bad for their legs, but it's also bad for their heart. So we can go in through a little catheter and expand that area that's narrowed and treat it with angioplasty and a stent to prevent it from recoiling, and then put that person on an exercise program that is going to help them modulate the plaque buildup in their heart and their brain and their legs as well. There are more invasive ways, but we try to avoid them, and those include bypasses.
Dr. Velasquez, thank you. Dr. Lamelas, good evening. Welcome. This next question is for you. Great to have you here. What are the major advantages of your procedures compared to open heart surgery?
Right. Well, just to let you know, it's a great question. Here at the University of Miami, we offer the entire menu. So we offer the full open heart sternotomy approach to the minimally invasive approaches, which are the least invasive approaches to the aortic valve, mitral valve, double valve, triple valves, and the ascending aorta. So we have a multitude of ways of approaching these pathologies, but my approach is one that I've been developing for the last 18 years, and I still don't think it's perfected, because what I've done over many years has been advancing the technique to make it applicable to many different pathologies. So the aortic valve, the mitral valve, 2 valves, 3 valves, ascending aorta, congenital cardiac defects, atrial fibrillation surgery, resection of tumors within the heart. All of these could be done through a minimally invasive approach. The benefits are, as I mentioned, it's the least traumatic way to approach the heart. So that means there's very little manipulation of the heart and less secondary side effects that the heart will undergo. In addition, these operations are the ones that we see the least transfusions, which in addition offer multiple benefits in the postoperative period. The recovery in the ICU is a lot quicker. The recovery in the hospital is quicker. And importantly, the recovery back to a normal lifestyle is incredibly different compared to the full sternotomy approach. So we've seen so many benefits with this operation that I think this is an exciting field or subspecialty or super subspecialty in cardiac surgery that I have a very close passion for.
Dr. DeMarchena, welcome. It's nice to have you here with us, sir, as well. What studies are being done? It's actually a two-part question. What studies are being done at for valvular heart disease? And I hear there are studies for treating high blood pressure with catheters. Is participating in those studies?
Thank you, Tony, for the question, and thank you for moderating this session. I don't know if you're hearing me. I suppose you are. So the first question was, what studies are being done for valvular heart disease? And Dr. Lamelas pointed out that at the University of Miami, we have an entire team of super specialists in all areas of heart disease, including valvular heart disease. And so we've been doing research along multiple lines to see how we can treat the valves of the heart. Starting back over a decade ago, we were the first sites in Florida and some of the first sites in the United States in doing transcatheter aortic valve replacement when it was at its infancy. And in reality, we actually even started working on that before that outside the United States in South America. Those trials led to the approval of transcatheter valve replacement, which is a way to do valve replacement in patients that are sick and elderly who would not be able to well tolerate a normal surgery. And we can do it with catheters alone without general anesthesia. We can change a valve. Sometimes the patients can go home as early as the following day after the procedure. Remarkable improvement in technology. Most of those studies were done as part of the University of Miami's group. On top of that, we are still looking at new ways to use those valves, such as in patients that have earlier stages of disease to see if changing those valves earlier improve outcome. And Dr. Lamelas may tell us later about some of his innovative work that he's doing on modifications of some of these surgeries so that they can treat patients that before couldn't be treated. We are also working on devices that will work to do with catheters, types of repairs in the heart. We have research trials looking at ways to put a ring around the heart without catheters. We are also doing research studies at expanding the use of putting a clip in the middle of the mitral valve to see if it improves outcome. And we're actually one of the first transcatheter valve to be approved for use in humans in Europe now was born out of a company that was here at the University of Miami, the Tendyne valve. So there's a tremendous amount of work being done there. In the areas of hypertension, the University of Miami and my group have been very interested in treating hypertension with catheters. And one of the therapies that we've been investigating is something that's called renal denervation, where in reality, what we do is we put little catheters in the kidneys, going into the arteries of the kidneys. We modify the nerves in the area going to the kidney so that the brain doesn't cause stimulation to cause an abnormality in the hormones of the body to cause an increase in blood pressure. By doing this, we can significantly lower blood pressure, and we're presently studying a technique where we use microscopic needles to inject alcohol, just regular ethyl alcohol, in the area of the nerves around. The preliminary work that's been done with this decreases dramatically blood pressure. And so we're looking for people for that study with resistant hypertension.
Fascinating. Dr. DeMarchena, thank you. Dr. Lamelas, as we were winding up with you, we got another question, and I think we need to follow up with this now. It has to deal with the valves. And you were talking about the minimally invasive approach, and you mentioned a lot of valves. The question was, can the mitral valve be repaired with a minimally invasive approach?
Well, the mitral valve is definitely one of the valves that we have the best visibility of through a minimally invasive approach. It actually gives us a truly anatomic visualization of the valve, and essentially every single mitral valve procedure can be performed through this access point. And mitral valve repair is something that's very special because many surgeons around the world talk about the fact that we should have reference centers. Just to put it in perspective, the average heart surgeon in the United States today performs 5 mitral valve surgeries a year. Here, we perform between 5 and 8 a week. So as the saying goes, experience counts. There's no doubt that with mitral valve surgery, the mitral valve is a dynamic structure, but we fix it when it's still. So you have to understand that this is not only a science, but it's an art, and it's a dynamic art. So you have to fix the valve when it's stationary, but understand that when the valve starts moving and the muscles in the heart start interacting with the valve, the anatomy changes. So, I mean, I look at myself as a plastic surgeon of the mitral valve, and we have so many different techniques. We have a toolbox of techniques in order to fix the mitral valve. But again, I think it's not one size fits all. It's not one technique for every patient. That's why experience counts. And I think that if you want an excellent repair, you really need to go to a team or a hospital that does this on a frequent basis. But definitely it is a valve that I actually, enjoy operating on the mitral valve, because I think it's a special valve, but it does require a lot of expertise to do it perfectly, and also to have a long-lasting repair and outcome.
Thank you, Dr. Lamelas. Dr. Goldberger, what causes the heart to develop extra beats?
Okay, thank you for that question, Tony. So I like to think of the heart as a house. And in your house, you have both plumbing and electricity. And the heart is the same way. It's got all sorts of plumbing and it has all sorts of electricity. And what drives the heart to beat is its own pacemaker. I think everybody's heard about patients who get pacemakers. Well, patients need pacemakers because their heart's own pacemaker may not be working. So actually, if you take the heart out of the chest, it will beat on its own. And what drives it to beat is its own pacemaker. And that's an electrical signal that travels throughout the heart. So the point here is that the heart's cells are all electrically capable. And some of those cells can fire not at the right time. And when some of those cells fire not at the right time, you actually get an extra beat. And patients feel that in different ways. Some patients don't feel them at all. Some patients feel extra beats, and some people feel what we call skipped beats, because those beats don't provide an effective pumping action, but they're still there.
Dr. Goldberger, thank you. Dr. Velasquez, going back to you, you mentioned this again with your opening remarks, that sometimes cardiovascular disease gets out of hand and blockages in the arteries of the legs end up causing amputation. Are vascular researchers coming up with new cures to prevent this?
Thank you, Tony, for that question. In prior years, the focus in vascular regeneration was cytokines and soluble hormones, essentially growth hormones that travel around the fluids of the body, including the blood, and can cause blood vessels to grow and regenerate. And what we've been able to find through research done here at the University of Miami is that sometimes those types of cytokines and growth factors end up with off-target effects that we don't want, that are not going to achieve the therapeutic effect that we want. So through research done here at the University of Miami Vascular Research Labs, we have discovered that actually there's a family of molecules that lives attached to the membrane of cells, and they're called adhesion molecules. And they end up generating signals that trigger the body to grow new blood vessels. And in particular, there's a molecule by the name of Eselecting that is excellent at doing this and integral to the process of regenerating beds of vascular vessels that can help with healing and can help with saving a limb. So we've been able to design a gene therapy approach that replaces that molecule and a gene modified cell therapy that brings extra regeneration to the tissue. And this is very promising research that perhaps holds the key to never having to incur an amputation in the future. It is in the preclinical testing phase. It will require additional clinical experimentation and research and development, but it's extremely promising, and it will be added to the many things that we have now clinically in the toolkit of saving patients from an amputation. No one should accept having an amputation before coming to the University of Miami because there's everything from medication to catheter-based technology to bypasses to now gene therapy and gene-modified cell therapy for vascular regeneration.
With all of these innovations, Dr. Velasquez, you're going to need a bigger toolkit, I think. But we just had this sent in, and you know, while we're talking heart, COVID is still on the top of everyone's mind. So someone wanted to ask you specifically, and it literally just came in, can I still, or should I still take, or must I still take my annual flu shot since I received my first dose of the vaccine?
Thank you, Tony. This is a very important question. The answer is absolutely yes. However, you might want to space them. So you might want to have a period of a few weeks, maybe a month between the two vaccination sequences. But absolutely, it is critical to receive the flu vaccine. It is protective. And it's also very important that as soon as available, that we take advantage of the COVID-19 vaccine. COVID-19 is essentially a vascular disease. It's not only dealing with the actual respiratory symptoms, which is what is most commonly known in the COVID-19 disease, but is dealing with the vascular repercussions, which include an inflammation of the blood vessels and can lead to clot formation, and it could even lead to progression of the pre-existing plaques that gets, that buildup that was there in pre-existing vascular disease that gets further destabilized by the SARS-CoV-2 or COVID-19 disease.
Thank you, Dr. Velasquez. Dr. Lamelas, we're back to you and back to your passion. How has minimally invasive procedures advanced in recent years? And is there any new innovation with artificial valves or the possibility of regeneration of existing valve tissue?
Yes, thank you. That's a great question. Well, all facets of cardiac surgery, like cardiology and vascular surgery, are constantly advancing. The things that I did in training, some of them are non-existent today. So it is an evolutionary process, and we are working on ways to minimize the trauma to the patient by many different approaches, not only just decreasing the size of the incision, but also decreasing the inflammatory responses that of the certain things that we do even by medications to try to decrease the inflammatory response of the body. As far as valves, every couple of years, there's an advancement in valve technology, not only on the tissue treatment on the valves, because we have three basic types of valves. We have biologic valves, which are either made out of cow pericardium or porcine pig valves. And then we have mechanical valves, which are made out of a metal called carbolite carbon. And then we have human cadaveric valves, where there are actually valves that come out of patients that are not deemed to be transplant candidates. So those are the three basic ones we have today, but the tissue technology is constantly evolving. And not only the tissue itself, but the struts or the little post or the setting in which the valve sits, because it's very important with the dynamics of the heart that it's made in a special way where there's less damage to the leaflets, and that will promote long-term longevity of the valve. We are interested in also, that has been done, creating a valve from a human, using the human's own cells and impregnating a biodegradable matrix. So in other words, there's a frame that looks like the valve tissue, and then the patient's own cells are deposited inside that valve, and then that begins to grow, and then that valve gets implanted in the patient. That's actually very groundbreaking technology. It's not used yet, but there's a lot of talk, and hopefully that will be the valve that lasts forever. I mean, we don't know, but but it's constantly changing.
Dr. Lamelas, thank you. We just had this sent in, and the question is for you. How important is cardiac rehabilitation following bypass surgery?
Well, I think cardiac rehab is important in any facet of surgery. I mean, it's important. I think what I tell my patients, the most important thing is to get up and walk and stay active, because if you're stationary, your muscles begin to atrophy and your progress will not happen. I mean, it's important to stay active. We have a very excellent cardiac rehab program here at the University of Miami, which we encourage patients to take advantage of it. But the least you could do is stay active after any type of surgery, because not only does it help with the muscles, but it helps with the respiratory system, with the GI tract, and in general it's important. It benefits every organ in the body.
Dr. Lamelas, thank you. Dr. DeMarchena, can patients with atrial fibrillation that can't tolerate anticoagulation for bleeding be treated with the Watchman device?
Tony, thank you for that question. Yes, this is device was years ago. We realized that patients with atrial fibrillation, one of the biggest problems with it is that it can cause, when the patients are not treated with blood thinners, it can cause stroke. And so what happens is, in a little piece of one of the chambers of the heart, the left atrium, when the person is in atrial fibrillation, the blood does not move well in that area. That's called the left atrial appendage. And in that area, you form clot. And then the clot from that little area can be flipped off and go to the vessels of the brain. It can also go to some of the parts of the body other than the brain. But the ones that we have the greatest consequence of is stroke. And so there are many patients that take blood thinners for atrial fibrillation and do very well with it. But there's a significant number of patients that cannot tolerate those medications for multiple reasons. And those patients before had to be treated with only aspirin and another medication called Plavix. They would help a little bit, but minimally at reducing stroke. So now what we can do is, with a catheter, we can go with the patient under anesthetic. We can go through to the left atrium, and inside that left atrial appendage, we can actually implant a little filter that prevents any clot from getting out of there. And then the patients still have to be on anticoagulation for a short period of time afterwards. But then after that, they no longer have to take anticoagulants. The reduction in stroke is almost identical to the reduction with anticoagulants. And obviously the bleeding risk goes down dramatically when you take the person off anticoagulants.
Thank you, Dr. DeMarchena. Dr. Goldberger, what is sudden cardiac death? And can you share your innovative efforts to prevent sudden cardiac death in the community?
Sure, thank you for that question. So sudden cardiac death is pretty much what it sounds. It's basically death that occurs in an individual who was otherwise fine 1 minute. Typical story. I just saw him. I talked to him yesterday. He looked perfectly good. And I heard last night he dropped dead. That's, the typical case of sudden cardiac death. Now, colloquially, many times, on the news or, the media will refer to that as, he died suddenly of a heart attack. Now, for us, that's not exactly correct, because we think about a heart attack as the closure of an artery where there's no blood supply, the muscle dies, and that's what we call myocardial infarction, or colloquially a heart attack. Most cases of sudden cardiac death are not that kind of a heart attack. Most cases of sudden cardiac death are due to heart rhythm disorders, as we talked about earlier. It's an electrical problem of the heart. And the two main electrical disorders that lead to that are ventricular tachycardia and ventricular fibrillation. And those are just very, very rapid rhythms that come from the lower chambers of the heart. and it makes the beating of the heart ineffective, and then there's no blood, and then death. There have been many advances in understanding sudden cardiac death and how to treat it. So the first, major advance is, we now know, and we've known this for now several decades, that patients who've had a heart attack or patients who have poor heart function or any kind of advanced heart disease are particularly susceptible to these kinds of fatal arrhythmias. So these are high-risk individuals. But what we've also learned is that if we want to look at the total number of sudden cardiac deaths in this country, which approximate about 350,000 per year, okay, so it's a huge number of sudden cardiac deaths per year. It turns out that the people who are at high risk for sudden cardiac death only account for a very small number of that total. And you might say, how could it be that the highest risk people account for the smallest, for only a small fraction of the total? That doesn't make any sense. So let me try to give you an example. So if you imagine, let's say that our general population had a size of 10,000 people, and they had a very low risk of 1%. So 1% of 10,000 would be 100. So you'd have 100 sudden cardiac deaths in that population. Now let's take a high-risk population that has, let's say, a risk of 25%. But let's say there's only 100 of those. So if there are 100 of those and 25% of them suffer sudden cardiac death, there are only 25 sudden cardiac deaths. So even though that 100 has a risk of 25%, they contribute only 25 cases, whereas in the general population, we had 100, or 4 times as many cases. So that's really the problem. How do we find that needle in the haystack in the general population? Because if we really want to impact that number of sudden cardiac deaths in this country, we have to be able to focus on these people who are at low risk. And in early work that I did when I was still at Northwestern, we identified a risk score that's very, very effective in identifying people who are at risk within the general population. So we can implement that risk score in the electronic medical record and calculate somebody's risk for sudden cardiac death, just like we do for a lot of other things, like the risk of stroke and atrial fibrillation, the risk of heart attacks. So we can do that for sudden cardiac death. And based on some of the early findings that we're seeing in these patients, when we identify those people, we are finding specific abnormalities that were otherwise undetected. We're finding occult heart disease. So people who had actual heart disease and they didn't actually know about it. So the risk score is, at least in its early phases, appears to be a very promising way to find heart disease that may ultimately lead to sudden cardiac death.
Dr. Goldberger, thank you. Dr. Velasquez, how do I know that my vascular expert is taking all of me into account when creating a care plan?
Thank you, Tony. That is a very, very important question. Vascular disease is a disease of the whole body. These are buildups of unwanted plaque in the heart vessels, in the brain vessels, in the neck vessels that feed the brain, in the kidney arteries, in the vessels that feed the legs. So a complete history, a complete physical exam that looks at every detail of the risk factors is very, very important. So that's how it starts. It starts by the specialists really looking at the A through Z of what matters relative to vascular disease for that patient. After that, then comes the optimal medical therapy, the aspirin, the statin, the blood pressure control. Then there's one risk factor that has to be looked at in very, very close detail by the vascular specialist, and that's the presence of either diabetes or prediabetes. Whatever was happening relative to atherosclerosis, once diabetes sets in, that gets tremendously amplified. The inflammation in those blood vessels worsens, the progression of the vascular disease worsens. So I spent a lot of time talking to my patients about understanding this little molecule that's called the hemoglobin A1C that we can measure in the patient's bloodstream. It needs to be reflective of a glucose control that is adequate, that is as optimal as possible. It should be around 6 or lower than 6. For normal people, between 4 and 5.5. For pre-diabetics, between 5 and 6.4, 5.5 and 6.4, and diabetics above 6.4. That is a molecule that every American needs to come to understand because it impacts their health, their vascular disease, it impacts their longevity. There has been classic studies showing that the lower the hemoglobin A1C, the longer that we live. So a vascular specialist, if they're thinking of the whole person from A through Z, is not going to jump into what procedure can be done. It's going to go through the history, the risk factor, the ways to modify the risk factors, the optimal medical therapy. Then if there's an indication for a catheterization, an angioplasty, a stent, a bypass, or enrolling in a clinical trial that does gene therapy or gene-modified cell therapy, then that vascular specialist is going to explain to you the reasons. What are the reasons for that indication and what are the potential risks and benefits? And it's going to go into a great detail. What are the alternatives? I spoke before about the toolkit of vascular treatments. It is a large toolkit. A good vascular specialist that is thinking of you as a patient is going to explain in that toolkit, these are the options. Everything these days has at least 3 options. And it is a matter of carefully considering the risks and the benefits. And then together, the patient, the vascular specialist, the patient's primary care doctor, cardiologist, together making a plan of care.
And making sure you ask the right questions. Speaking of that, we just had this sent in for you, Dr. Velasquez. And the question goes like this: how long does and how long can a stent usually last in the carotid artery?
Yes. So the generation of carotid artery stents that we now use in clinical application are very durable. They are FDA approved specifically for that particular artery, the carotid artery system. And typically, once we place them in, they're for life. And they can last forever. They don't need to be removed. They don't need to be replaced. There is a small percentage of patients that might develop a little bit of recurrent plaque. And so we do monitor these stents after they go in with non-invasive techniques like ultrasound Doppler. And in most patients, if a little bit of recurrent plaque comes in, it tends to be the plaque that you see on the surface of the skin when you heal a wound with scar is smooth. It tends to be a little less prone to an embolic stroke. So for the most part, we just observe it, and in only rare occasions, we may need to re-intervene for a buildup of plaque after stenting procedure.
Thank you, Dr. Velasquez. Dr. DeMarchena, this was just sent to us as well. You hear over and over again that heart disease is a precondition that could make COVID-19 worse in a patient. However, I'm not clear as to which heart disease. Can someone in the panel clarify if cardiomyopathy is one of the high-risk preconditions that can make COVID-19 worse in a patient?
Yeah, wonderful question. Interestingly, today for medical grand rounds at the University of Miami, we had Dr. Anthony Fauci. Everybody knows who Dr. Fauci is. He's been basically the czar of COVID epidemiology and therapy in the United States. And we went over many of these points. So Dr. Velasquez earlier told you that COVID is a vascular disease as well as a lung disease. And we now know that even many of the things that are happening in the heart, and Dr. Goldberger can maybe amplify on that later, because he's doing a study on COVID and the heart. But pathological studies have shown that you get microscopic little teeny thrombus or clot inside the microscopic vessels of the body, causing many of the problems that we're seeing with COVID. Now, there's a lot of diseases that predispose you to having worse outcome with COVID. And the cardiovascular disease is one of them. Almost all of the cardiovascular diseases can make, if you get COVID, worse. And but the big ones are obesity, diabetes, coronary artery disease, and hypertension. Those are the biggest ones that predispose you for problems. Now, if you have a cardiomyopathy, you already have damage to the muscle of the heart. And so therefore, if you were to get COVID and you had any problems with that, it would be amplified. Maybe Dr. Goldberger could also answer a little bit more on the COVID heart study that we're doing.
Yeah, thank you, Eddie. I'd be delighted to just amplify a little bit on that. So, you know, the COVID, the virus enters the cells basically through a lock and key mechanism. So the key for the virus is the spike protein, and that's what the vaccine targets, for example, is the spike protein. And the lock that the cells have that really provide the entry for the virus is a protein called ACE2. And this is a protein that's present in a lot of different cells, but it actually protects the heart. It's actually designed to protect the heart. And we know, for example, that there are medications called ACE inhibitors that are used that help people with heart failure. And that medicine is basically provides the same kind of effect that the ACE2 receptor in the heart cells provides. So the heart has a lot of these keys. And so the virus has this particular tropism for the heart. And you know, it's well known that many viruses can cause myocarditis. And Dr. DiMarcena mentioned there are other mechanisms by which the virus can cause ill effects on the heart. Certainly in people who are hospitalized and have very severe illnesses, there are, you know, you can have low oxygen, you can have a lot of different issues that lead to heart disease. But we've been studying particularly our athletes who mostly have very mild cases of COVID-19 infection. And based on rules that the athletic societies have come up with, they all need to be screened before they're allowed to return to their athletic activities. And we found that about 4 to 5% of young, otherwise healthy athletes who've had COVID have evidence of what we call myocarditis or inflammation of the heart weeks and weeks after their initial COVID infection. So, you know, this virus we have to think about very seriously as a virus that does have a tropism for the heart and can affect the heart even over a long period of time after the infection, and even in very mild cases.
Dr. Goldberger, thank you. This hour is flying by, so we're going to try and get a couple more questions in. So doctors, if you could, for the next couple of questions, be as brief as you can. But Dr. Lamelas, what would qualify someone for a minimally invasive cardiac surgery rather than open heart surgery?
Right. Well, primarily, the minimally invasive surgery is to address valve disease. But on the other hand, we also do minimally invasive coronary disease where we bypass, we make a small incision on the left side as opposed to the right side. So the valve diseases are all approached to the right side of the chest because most of the valves are behind the heart, believe it or not, and they're easy to work with. The coronaries, we approach them through the left side. And we would usually harvest an artery from behind the chest called the mammary artery. and we would connect that to the most important artery in the heart, which is the left anterior descending artery. And what we also have worked together with my cardiology colleagues is doing a hybrid type approach where I would use this most important artery to bypass the most important artery in the heart. And then the cardiology colleagues, Dr. Demirchen and his group, would go and place stents in the other coronaries, which are, believe it or not as important as this artery in front of the heart. So we've done a hybrid approach when it comes to coronaries. Now, the only case that I would say is not a candidate for a minimally invasive valve operation is somebody that has significant triple vessel coronary disease, or if they have multiple blockages in all the arteries in the heart, then we'd have to approach them through a conventional sternotomy. But on the other hand, if they had one or two arteries that can be stented, then they would be absolutely a candidate for a minimally invasive operation. I like to say that we have an all-comers approach to minimal invasive surgery. There's really very, very few people that are not candidates unless they need multiple bypasses.
Thank you, Dr. Lamelas. Come as you are, so to speak, right? Dr. Velasquez, what are novel cell and gene-based therapies in cardiology that excite you the most?
Yes, thank you. I mentioned this a little bit earlier. There's this a family of adhesion molecules. They're proteins that are anchored, tethered to the surface of the cell. And one of them is called the Eselecting adhesion molecule. And we've been able to regenerate the vasculature in preclinical models using direct gene therapy to upregulate this adhesion molecule in the tissue that's affected by critical limb ischemia. And we've been able to heal wounds and improve the running capacity and the caliber of the skeletal muscle fibers using cells that were gene modified outside the body and then reinserted into the problem limb. Now, critical limb ischemia is the end stage of these processes that build up plaque in the leg arteries. And although we have angioplasty stents, atherectomies, bypasses, all of these clinical avenues, in many patients, as the disease progresses, we run out of options. And it is in those no option patients where we ultimately need to recommend amputation. We believe that with Eselecting gene therapy and Eselecting modified cell-based therapy, we will be able to save many patients in the future from needing an amputation by being able to regenerate the vasculature of the leg and thereby protect the muscle fibers and enhance the running capacity and the walking ability.
Thank you, Dr. Velasquez. Dr. Lamelas, we're going to squeeze this last question in for you. Can you quickly tell us about the Miami method and how does it offer those patients with aortic valve stenosis a safer surgical option?
Right, that's a great question. Well, just to emphasize, many years ago, like any cardiac surgeon, we start by learning the operation through a full sternotomy approach. But as the years went by, I started thinking that cardiac surgery had to continue to evolve in lesser invasive approaches like every other specialty in surgery. So in 2003, minimally invasive surgery was not as advanced. So I started dabbling in it and started applying it to high-risk patients first, and I saw these patients benefited from this procedure. So then I started moving on into the lower-risk patients. And then in my mind, I always wanted Miami to be recognized in cardiac surgery, and unfortunately, it wasn't. But tagging the Miami method, which is a minimal invasive approach, just about every heart valve to Miami, it has received international recognition. And even today, meeting a patient from the Dominican Republic, he specifically said, I want the Miami method. So it's gone not only to the Caribbean, but throughout the world. I've even operated on patients from Dubai, for instance, that have asked for this approach. So I think for me, it was very important for Miami to have ownership of something very special. And that's where the Miami Method came in. And the Miami Method is specifically to address any type of valve pathology through the least invasive approach possible that translates into numerous benefits for the patient in the postoperative period.
Dr. Lamelas, thank you so much. I don't even know where this hour went. This was remarkable. What an amazing hour. Before we close, though, I think it's important that Dr. Velasquez, we bring you back for just some final thoughts.
Thank you, Tony, for moderating this important discussion. And thanks to all of you who were able to participate. We appreciate the opportunity to answer your questions, and we appreciate very much your interest in what we do and the support that you provide the community. I want to also recognize the work of our faculty and our staff for their tremendous dedication to our patients. They're truly committed to being among the best in the world and the best at what we do. The enthusiasm, the commitment, and the expertise of all of our physician and physician scientists really reflect the kind of drive that we need to successfully develop new treatments against cardiovascular diseases. In this regard, philanthropy helps to ensure that we have the best people and to provide them with the best resources and optimal infrastructure. So I want to acknowledge the generosity of the Board of Trustees, the University of Miami leadership, and our loyal donors. You continue to help us set the new standards of care and come up with the cardiovascular cures of tomorrow. You inspire us to go above and beyond to find solutions that will make a difference in hundreds, thousands, and millions of patients' lives. So thank you so much for your time, and thank you so kindly for allowing us to share our thoughts with you this evening. And Tony, thank you so much for moderating this session.
Dr. Velasquez, it is truly my honor. I mean, truly, truly my honor. At the beginning, I said this was the Mount Rushmore of U Health Heart. And if any of you out there don't agree with me, then I don't know. Because first of all, we want to thank everybody for participating tonight. But I truly think you'll all agree that tonight was not only informative and so cutting edge, but it was truly, as Dr. Velasquez says, truly inspiring, because all of these doctors are inspiring. This group that we had with us tonight are not just experts and world renowned in their field, they're passionate and dedicated to keeping one of our body's most essential organs and our engine room healthy and fit. And think about this. All of them are part of the U Health family. How blessed are we? Please remember that a full recording of this program will be posted online. Look for that link in coming days. And in a moment, you're going to see a survey about tonight's town hall on your screen. It literally takes less than a minute. I've taken it before. We need your feedback, because you see, with your feedback, it's going to help us understand your interest, and it's going to help improve our program overall. Well, as always, we wish you and your family good health. Stay safe, stay healthy, stay together, and remember one thing: it's all about the you. Good night, everyone.